Oops. Well, we're live now. Somebody hit the webinar button. Would y'all like me to we're a few minutes early. Would you like me to go ahead and start off with reading my ACCME information and then pass it off to you, Dr. Hajipanias?
Wait till it's 7:30, I think, if possible.
Can you wait a little bit, Tim, or I don't know what
Yes,
happened?
I can, but we're live in front of everyone at the moment already.
Okay, well, it's all right. We'll behave.
All right.
Might as well
Hey
jump
guys,
in
how are
then.
you? Good to
We'll
see
take
you.
so much time to talk about the webinar, then might as well jump in.
Yeah. Maybe Tim, as you introduce the AANS. Okay.
Sure.
Danny and Paul, I'll just give a brief introduction and then I'll let you guys kind of introduce the skull-based webinar series and then.
Sounds great. I think we're live now. Yep.
Okay. There we go. There's one.
Hey guys.
Hey Juan.
Hey,
Hola.
how are you?
How are you?
Good, how are you?
Good. Thanks for getting on.
Thank you.
We are live now. Tim, do you want to start us off then, and then we'll get going here?
Sure, I'll go ahead and get started. So welcome everyone. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for integrity and independence in accredited education, the AANS is required to disclose the activity audience, the relevant financial relationships of the planners, faculty, and other individuals in control of content for this activity. Those that have disclosed relationships with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with the ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of this week, participants will receive an email notification of enrollment to claim credit. For any issues or questions regarding claiming credit, please contact education@aans.org. Now to get us started, I'd like to turn it over to Dr. Hajipanias.
Good evening, good morning, good afternoon, wherever you are. Thank you for joining us tonight. I am so excited. We are launching our skull-based tumor section webinar series. Really excited to have these leading speakers engage us tonight. I do want to acknowledge the efforts of the AANS for helping us put this together. For the viewers who can't make it tonight, these are all recorded. They're on the tumor section website, as well as the AANS YouTube channel. They're actually connected through the our website as well. And I do want to thank Doctors Paul Gardner, Danny Prevadello, and Gustavo Padilla, who really have put a lot of effort in launching this tonight. And I'm going to turn it over to them because they've done a lot of work to get this going, and we're really excited that they've made this happen. Thank you very much.
Yeah, thank you, Costas. So I'd like to welcome everyone to our first webinar related to skull base for the tumor session of AANS and CNS. So our plan is to have at least once a month a webinar involving skull base surgery, endoscopic and open approaches, and good discussions. Our plan is to have this in a short and effective way, and in a way that we're going to start today with endoscopic skull base surgery to the paracellar region. The way we're going to start today, we're going to have two speakers. The first one will be Dr. Juan Fernandez Miranda, who is going to talk about the endoscopic approach to the sellae paracellar region with emphasis on cavernous sinus. And we'll try to keep it short, directly to the point, with important tricks and tips that Dr. Miranda is going to give us. And then we're going to move to Dr. Gardner, who's going to show us some tuberculum sellae meningioma. And we're going to try to keep it short so then we can discuss some cases afterwards, and we'll try to moderate and bring some important aspects. So to start, I would like to ask Dr. Miranda to share your screen and give us some of the nuances and important aspects of surgery to the cavernous sinus. Thank you.
Wonderful. You guys see my screen? Let me see.
Very well, yeah. It's in the presenter mode though,
yeah,
Juan.
Let me swap. Now it's good, right?
Perfect.
Okay. Thank you guys for the invitation. I really much appreciate it. This is a special treat for me. Having started my journey with you, Danny, and with Paul in Pittsburgh a long time ago, 2008. So it's been a long road, and you both have been great friends and inspirations in my career. I learned from you so much. So great to have you. Looking forward for the discussion. So I'm going to try to make it brief and focus on pituitary adenomas with invasion of the cavernous sinus. And this is a journey of anatomical research over the last 15 years that have led to surgical innovation. And this is research we started in Pittsburgh, and we've continued at Stanford. And also I'm going to show you the clinical applications of this research, how this is impacting outcomes during my now 7 years here at Stanford with over 1,000 endonasal cases during this period. First, we need to understand the dural layers of the sella. We talk about this extensively. The two dural layers, how they split to form the cavernous sinus, middle wall and anterior wall. And I want to emphasize the importance of the ligaments, and in particular, the cruritoclenoidal ligament, which is the ligament that anchors the middle wall of the cavernous sinus superiorly to the clenoidal carotid artery. And actually, there's a paper coming out in the next few weeks, I think, at AANS, where we study the variations of the CCL, because it's such an important ligament. When you disconnect the middle wall of the cavernous sinus, understanding these variations is of great importance. And these dural layers, ligaments, are the base, the anatomical base for the selective removal of the middle wall we described some years ago. And this is a step-by-step technique, again, based on the anatomy of the middle wall of the cavernous sinus. And over the years, we've collected knowledge on this technique. And one of the first things I want to share with you guys is we've learned, based on this experience, how there are not all middle walls are invaded the same way. There are different patterns of invasion of the wall of the cavernous sinus. There's another paper coming out in AANS soon. And, and we describe how there can be a focal or microscopic invasion, while other cases actually grow within the wall of the cavernous sinus. We call this wall thickening. And then we have the typical pattern of wall destruction that we're more familiar with. The relevance of this is that each middle wall invasion pattern has very distinct characteristics, and also difficulty, different levels of difficulty when removing. Without going in great detail, wall thickening is more typical of recurrent tumors, ACTH secreting adenomas, often with adherence to the carotid artery, so more difficult than focal invasion, for instance. We've also learned, for example, things like corticotroph adenomas. If they are secreting adenomas, they are much more often invading the wall in a focal or thickening way, while if you have silent corticotroph, these are typically causing wall destruction. So different type of adenomas behave differently. I often get the question of do you always remove the middle wall of the cavernous sinus? And of course, the answer is no, only when I think it's invaded. This is an example of a case where we can really see the middle wall really nicely after the tumor resection. The middle wall is nicely pulsatile. There is no tumor that I can see on it, so I'm not removing this wall. But I always like to see the wall well to make sure that it doesn't need to be removed, especially for functional tumors. Now, when I have some intraoperative suspicion on invasion of the wall, like in a case like this, we would call this microscopic invasion, then I might remove the wall, especially if it's a functional tumor. This is a case of a pediatric ACTH secreting adenoma. The tumor has been removed, separated from the wall, but I don't like the plane. I think the plane, there could be some macroscopic implants on the wall of the cavernous sinus. So I'm removing the wall, and this is relatively easy. This is the easiest removal of the wall you can do. The wall is not involved, it's not stuck to the carotid. You can nicely remove it, and this gives you an extra level of safety in terms of being able to achieve complete tumor resection. As you will see, doing this adds no morbidity to our patients. Now, sometimes it's not just microscopic, but it's actually a focal implant, a small focal implant, like in a case like this. You can see even on the exposure, that little whitish extension of the tumor suggests the tumor is into the wall of the cavernous sinus. And as we dissect the tumor, actually find tumor embedded on the other side. So it's a case where both walls of the cavernous sinus have been invaded, both medial walls. So I'm resecting first on the left side. And then as we go to the right side, just look when we open how there is a little nodule of tumor right there where the dissector is. And that little tumor is growing or stuck to the wall of the cavernous sinus. So the only way to really remove that safely or entirely is to open the anterior wall and then dissect the middle wall, and you see the inferior hypophyseal artery, and then remove the wall entirely of the carotid artery, and that way you get a complete tumor resection. Now, different than those are tumors that are actually truly embedded within the wall. The wall is actually thickened, as you see in this illustration. And you see it in this case of a patient with Cushing's disease. If the pediatric case, you can see on the MRI that the tumor is at the corner. And when we go on the sella, on the pituitary side, you don't see much tumor. But we open the anterior wall, and you can see that the whole wall contains the tumor. We're disconnecting the ligament there, inferior paracentral ligament. Now we have to separate this from the carotid artery. But you see how the wall is several millimeters thick. And the tumor is contained. It doesn't spread into the cavernous sinus, it's just in the wall. This is another level of difficulty. It's a bit more difficult. You have to dissect this whole chunk out of the carotid artery, which can have some attachments. But you dissect it entirely. You see here, the last attachment there is the inferior hypophyseal artery that we are now transecting. And this allows us to do a complete tumor removal of that tumor that was growing within the wall of the cavernous sinus. And you do that, and these patients do have an excellent outcome after doing so. Now, the issue is that if you don't do this, it happens like in cases like this. This kid had 2 previous operations. You can see the hypointensity on the wall of the cavernous sinus. So we go back this and remove it. This is a frequent source of recurrent or residual disease on patients with Cushing's, and we've done a good number of them. Now, I've also seen something pretty unique, and this we're also publishing this on our CCAL paper, and is that there are some tumors that actually grow within the fibers, not just of the wall of the middle wall, but the fibers of the CCL. As you see in the illustration, tumor can actually grow into these fibers. And even a tumor like this, a patient with acromegaly. And I'm going to skip it forward, but we remove the middle wall, but that CCL is very thickened and actually has tumor within it. Understanding the CCL and the multiple variations, it really has become very important and actually difficult because the CCL has multiple variations, different attachments. Understanding those, I think, is key for cases like this. And this is another level of complexity because the CCL is tightly adherent to the carotid artery. So you cannot really get a clean plane. You have to tangentially cut it, trim it, and then coagulate the rest. Something even unique like the case like this, a case that done somewhere else with a very good resection and a very large tumor, but this patient had recurrence of disease. And if you look at that, there is a tiny bit of tumor right there where the blue arrow is. That little bit of tumor is actually embedded in the CCL. Pretty unique situation. but the more you know, the more you see. So I see these MRIs and I see the tumor is right there. So we do an operation as usual, and you see the tumor is right there. We are seeing it right now. But again, another level of difficulty because this is tumor embedded in the CCL, very adherent to the carotid artery. So you have to very carefully dissect this tumor from the, in this case, the clinoidal segment of the carotid artery. And you can see how I'm literally peeling this off the wall of the carotid. You can even see a superior hypophyseal artery branch or trunk, better said, coming on the clinoidal space. And we finally can detach this whole tumor. Again, the CCL is something you can typically not fully transect of the carotid. You need to trim it tangentially and then coagulate the rest. But typically those small fibrous attachments you coagulate, most often they won't have tumor on it. So you get a nice clean resection and an intact carotid, as you see right here. Now, it can get even more difficult, which is a tumor like this, patient with acromegaly. You see the tumor is embedded in the wall, but very adherent to the carotid, and even can extend into the cavernous compartments from that thickening of the wall. It can break through the wall and enter into the compartment, but still the wall is very thick. And these cases are difficult because of the degree of attachment to the carotid artery. And I'm going to make it quicker, but now we remove the cellar portion. Now we open the cavernous sinus, and you see how thick that wall is. You can see the yellow tissue going through wall or nodules on the cavernous sinus side of the wall. And this is very stuck to the carotid. These cases are very difficult. So removing the middle wall here is another level of complexity, risk. You can see tumor that is extending to the posterior compartment of cavernous sinus of that wall. And this, again, is more complex, but extremely important. If you don't do this patient will not get in remission after surgery. But with very careful technique, as we develop our ability to do these things safely, we can do a complete tumor resection, and then this patient also get in remission, long-term remission. That's the thickened wall being entirely removed. Now we go into the more classic situation where we have invasion of the wall, destruction, and then we go into different compartments. For example, going to the inferior compartment, we recently published about the inferior compartment anatomy in the sympathetic nerve, and I'm gonna jump through this just to show you, at the very end, how we are separating this from the sympathetic nerve that you see right here. And this is the carotid artery. Now we're trimming this of the carotid artery, again, aiming to obtain a complete tumor resection, as you see right there. And I like to use indocyanine and green at the end of these operations to identify the carotid, make sure that I don't see any shadows on the carotid artery that could represent a tumor. And then posterior compartment, another area that is quite difficult. We're looking at the back of the cavernous sinus where we have posterior petrocondylar ligament, Gruber's ligament, Meckel's cave is located laterally. And then there's another area where tumors can extend. And this makes this operation more difficult. Another case of a growth hormone that I went all the way behind the carotid to remove the tumor that was embedded in the superior and posterior compartments. And finally, lateral compartment, the most complex one, the one we hesitate to go the most because the risk is the highest. Rarely we get into these areas where we truly mobilize the carotid artery out of the, from medial to lateral, so we can get lateral to the carotid. And right now we're going to the clinoidal space there, that's third nerve, and we are cleaning the tumor lateral to the carotid. And again, we do this in more selective cases because the risk is clearly higher of postoperative sixth nerve palsy, especially. To wrap it up, briefly, of resection rates have been, I think, excellent in terms of both functional and non-functional tumors. As you see here, with remission rates in the 80 to 90% rate. For example, specifically for acromegaly, you can see how our rates are almost in the 90% for first-time surgery. We can see here, we are polishing this, preparing this for publication, 100 consecutive endonasal cases for growth hormone adenoma with remission rates 84% in first surgery. But the benefit in these tumors also, you add adjuvant therapy, medication and or radiotherapy, CyberKnife, we are able to achieve remission in 98% of the cases. And this is pretty remarkable because most of them are now in remission after surgery plus something else if needed. And you can see here the IgA levels on all these categories, with and without cavernous sinus invasion. The remission rates are really improved. With Cushing's disease also, we have remission rates on the 90% approximately, but on the redo cases, they are worse. These Cushing's disease are more difficult. Even in cases we have a complete cavernous sinus clean out, there is no residual tumor. You can see some of these patients do not get in remission, unfortunately, but they do need often radiosurgery in that case. Lastly, complications. Of course, when you do this, you always need to be very thoughtful on analyzing your complications. Fortunately, the number one complication is that you worry about, of course, is carotid artery injury. We only had one case in this series, and it was during the exposure, not during the cavernous sinus, and the patient did not get a stroke. It had no consequences, fortunately. So we can do all these carotid artery dissections with great level of safety, but this requires a lot of expertise, of course. The second part is looking at diplopia rates, and diplopia rates are actually quite favorable, going from 5 to up to 10% in redo cases. But the nice thing is these are temporary double vision. Most of them are 6-nerve pulses that they recover. Most of them are 3 months. Some of them do need 6 months to completely recover. So this is difficult surgery. It's all about being able to navigate around the carotid. This is, a word of caution for those trainees that are, or less experienced surgeons that are looking at this presentation. Please be very careful. This looks very risky, and it is very risky if you don't do it with a level of technical skills and experience that is required. It reminds me when you go to El Capitan and you see someone like Alex Honnold trying to go freehand. First, he does a lot of training with all these ropes, and then he goes solo with his own bare hands. This definitely looks absolutely very risky, but he can do it. He can do it because he has a lot of training, a lot of expertise, and he's been preparing his whole life to do this, and that's what we are doing here. I just want to warn you that this is possible, this can be done, but please do it at your own pace and being careful with application of these techniques. It can be life-changing for patients, but you need to keep your complications as low as possible. Thank you very much. I appreciate your invitation, and I'll be happy to take any questions.
Thank you, Juan. Thanks so much. Amazing presentation. So I'm going to leave the questions for the end. I actually do have a couple questions for you, so we'll just keep it to the end. And now I'd like to have Dr. Paul Gardner presenting on the tuberculum sellae meningiomas, and then we'll do a quick discussion at the end if we have time.
Thank you, Danny, and a special thanks to Costas for really pushing us to do this webinar series. Again, I want to emphasize that I think you'll find, even from looking at this webinar, that really our design here is to try to provide information that's useful to those out in practice. A lot of times skull-based surgery can be perhaps presented in a very niche way, but we really want to focus on topics that are very relevant within skull-based surgery, whether it's tumor biology, modern treatments of it. So I hope you'll find this series of 8 monthly webinars useful in that fashion. Along those lines, I'm going to be talking about tuberculum meningiomas, which I think are a particularly hot topic and really is skull-based. But of course, every neurosurgeon comes up against these because meningiomas are quite common. So these are my disclosures, which are really not directly relevant for this, but endoscopic endonasal approach has become incredibly common and popular, and of course, endoscopy really has taken over as the preferred approach for most pituitary surgery. There's a whole series of modules of approaches, and really the most next accessible beyond pituitary surgery really is the transplanum approach. And here we can see the sort of standard anatomy that we might see from an endonasal perspective, where we can see the tuberculum and the prechiasmatic sulcus, the sphenoid limbus, which extends out to the falciform and the planum. And all of these structures, and understanding this is anatomy, is really what gives us the ability to extend upward. Now, when one of the critical steps when we're doing this is the bone removal really has to be quite extensive. These might be termed as, quote, minimally invasive approaches, but they're really minimal access, but maximally invasive. And I think that's important to recognize. And the bone removal even includes, of course, optic canal decompression, just as one would do from an open approach. And this is, of course, a critical step. Equally important is that the resection phase, just like the exposure phase, has to be done in the same way we would do with open surgery. If we don't apply those same concepts, we won't have the same results. And that means following the ideas of internal debulking with extracapsular dissection and all the typical types of microsurgical techniques that we would use. Here's a classic tuberculum meningioma, and you can see causing a bitemporal hemianopsia. And this is showing the step here of the optic canal decompression, which is done very widely. One important thing to notice here is that as you see, as the tuberculum comes off, you can see the thickening and hyperostosis of the tuberculum. You can also see how the capsule of the dura of the tuberculum is involved, and you can resect the diaphragma through this approach, in addition to, of course, a complete tumor resection. So this really allows a potential Simpson grade 1 resection. And here you see just the application of microsurgical technique. I'm not going to focus too much on surgical videos here. Certainly, understanding of the technique is critical, and there are plenty of courses designed to teach this, and that kind of practice, as Juan pointed out, is really critical. But, internal debulking, extracapsular dissection, following all the same concepts we would do from an open approach, sort of working from the inside out, finding the arachnoid plane, continuing to debulk the tumor, really is critical. And at the end here, we can see the last attachment of the tumor on the medial optic canal. And again, even that dura gets involved, and we can follow the optic nerve with an angled endoscope all the way out to see the ophthalmic artery here, which of course has to be preserved. And then we have this decent sized defect at the end, which of course we have to close. And this is where it becomes critical working with our ENT colleagues. But you can see at the end, the brain is untouched, the optic chiasm is untouched, as is its vasculature. And this perhaps provides one of the big advantages to the approach. And here you see the flap going up. And here's the post-op with an improvement of vision and a complete resection of that tuberculum component. Now, there are some clear natural advantages with vision, but of course, CSF leak remains an issue. And just taking a quick look at our own institutional updated series, and this is important to use the McGill-McDermott grading scale, because I think it's becoming a little more accepted, at least as a way to try to understand the complexity, because not every tuberculum meningioma is the same. And this essentially looks at size, optic canal invasion, and a critical thing, which is arterial encasement, which is part of the learning curve of any approach, especially endonasal surgery. Here you can see predominantly female, and you can see the smattering of different McGill-McDermott grades, all the way up to multiple at grade 6, just showing the complexity across which these can be dealt with endonasally with the right experience. And gross total resection, which in this case means Simpson grade 1 resection, was achieved in this series in 72% of cases, with only very rare cases of subjective visual field decline. And of course, CSF leak really dropping dramatically over the years with the advent and the perfection of the nasal septal flap. Of course, A2 injury is a critical potential complication of this, although we can do the vascular dissection. This is part of the McGill-McDermott for a reason. And this is looking at recurrence. And we found that high Ki-67 and of course subtotal resection, as you might expect, were key factors. Well, where are limitations? Where are the anatomic regions that you can't really access? We looked at all 100 cases of all kinds of different locations of anterior skull-based meningiomas performed endonasally, and it kind of makes sense. If anything lateral to the mid-orbit and anything lateral to the optic canal or the optic nerve, these are the natural anatomic constraints and limitations, and sure enough, that's where there's residual left. But again, remember, these are midline tumors that usually invade the medial optic canal, and they don't often extend over the top of the optic canal. So these were, you can see the different factors, including the total MM score that was not associated with recurrence, but a high Ki-67 was on multivariate. So again, looking back at these advantages, this lower Simpson grade resection, there might be some debate, does Simpson grade resection matter? Does it matter if I, reach from a craniotomy and coagulate the dura or get a more complete resection, given the concerns about CSF leak and vascular dissection? Well, there is some pretty strong evidence out there now. This is an international study with 40 different sites and almost 1,000 patients comparing this over time. And what you can see here is that there were a greater number of patients who had a worsening in their vision with a transcranial approach as opposed to an endonasal or transsphenoidal. At the same time, despite a similar gross total resection rate, there was a higher CSF leak rate, so a big trade-off for this because of that resection of the dura. Interestingly enough, though, the risk factor for recurrence, that's Simpson grade 1 resection that you can really only do from below unless you do a really big subfrontal approach, a much lower risk of recurrence with an endonasal resection. So that Simpson grade 1 resection really seems to matter. And some of the conclusions from this that I took away from it is that surgeons really need to be well trained in both approaches and understand to be able to select what's best in their hands, depending on the patient's anatomy, what the patient's desires are, and your own learning curve. But if you can get a gross total resection, you will have a lower recurrence rate after endonasal surgery. And that, again, really comes back to the advantages that it can provide with a direct approach to the base of the tumor. Endonasal surgery and craniotomy, I think, are sort of trying to find this balance with each other. And this is so-called Scott's parabola, where a surgical technique becomes part of the standard treatment and gets compared to the known standard treatment. Much like the Dunning, sort of the opposite of the Dunning-Kruger effect, you really want to follow the learning curve and understand how to apply this. A quick plug, of course, for the Pittsburgh course, for anyone interested in more endonasal surgery learning, and as well as a free online and a plug also for the European Skull Base meeting coming up in December. So thank you, Danny, and we'll turn it back over to you for a panel discussion.
Perfect. Yeah. So before I ask questions to Juan, I just want to make a comment on this study that McGill presented there, because I agree with everything you said. Just one extra point that was a conclusion on that study is that patients that already present with vision loss, the outcome for vision preservation or avoid further deterioration of vision was much better with endonasal. That was statistically significant as well, just as another point. So Juan, I'm gonna just ask a couple questions because the idea with this webinar is to be direct to the point and with the most important things. We want to finish in 10 minutes. So I just want to show you this. As we are seeing this patient and use this to ask my question. So my question is, now you're seeing this as an OSP4 there, like right invading the cavernous sinus on the left side is like your type of situation where it's fully invaded there. You know, my experience with this, sometimes you don't even find the medial wall, right? I want you to comment on this and also give us your insight. Are you still seeing my screen or?
Yep.
Just give me your perspective on what if this is a non-functioning adenoma, because I think that it's very clear for functioning where you want to be aggressive and remove the medial wall, even if it's just a little bit there. But tell us what's your insight about this? Like, let's say patient is just have bitemporal hemianopsis and no double vision and this type of tumor. So what's your perspective?
So this being non-functioning, let's say middle-aged patient, I think this is a case where the wall is destroyed. You won't see any wall in there. The tumor has just broken into the cavernous sinus. I would try to clean in the cavernous sinus as much as I can, but I see there is lateral compartment invasion, and I think that's very likely gonna be is gonna stay in there. So I will probably clean the cavernous sinus, the inferior compartment, the posterior, the superior, but there might be a lateral compartment tumor I cannot get, but I see in that axial lateral to the choroid. It's very difficult to get there. It's perhaps possible, but the risk of diplopia is too high. So I would probably leave that lateral compartment for follow-up or radiation if it comes back with a high KSD7, for example.
Yeah, since you brought that up, tell us more. Let's say you leave a little bit of residual there, lateral to the carotid. The patient does great.
Yeah.
What is your indication in terms of timing? Do you watch the residual versus going ahead and give radiation to the residual in the cavernous sinus for non-functioning?
I think if the patient has a typical histology, the tumor, I would probably watch it. Only if I see something concerning the histology, I would radiate.
Yeah, and now let's say it is an obvious residual there, is an os before, and let's say now this patient has Cushing's disease. Are you more aggressive with that attempt to clean the lateral compartment in a Cushing's case, like similar to this?
I probably would, although there have been cases that I've been in the lateral compartment that is just so fibrotic that I cannot do much. In that case, I won't risk it. If I have to leave residual, I would. But being functional, I would try to do as much as I can, I think, safely.
I think the difficult question with these, Danny, really is biology. And that's kind of the question one that, as these boundaries get pushed, that certainly when it's touching medial cavernous wall, you feel great about getting a margin. This is head and neck surgery being applied. But some of these tumors, like the one Danny just showed, or even the ones where you get thicker invasion, I think they're really biologically different. And so our chance of really providing a long-term cure of these patients has got to be different. I think we still need to better understand what drives these. And there's, we know TPIT1, for example, for corticotroph or ACTH, is a critical piece. But I think we don't understand well enough what's driving the biology of some of the more invasive tumors to be able to better select and to avoid complication when it's appropriate.
Yeah, I agree. This is something I learned from Dr. Laws. I asked him for advice once, and he said the most important thing is to understand the disease. Yeah. So, you independent of approaches, you need to be, working hard to understand the disease more and more. Definitely. So just to finalize with you, Juan, before I ask Paul a question, this is an example of extremely fibrotic one that I did for this young girl. Actually, it's her 20s. I was disappointed, to be honest, when I saw this was my post-op after endonasal. And when I look at this, what would you do now, knowing that this was an acromegalic in her 20s? Would you try to go endonasal again, or would you try something else? Or would you just radiate?
I think if I've done my best endonasal and there is still significant residual, especially in the lateral compartment, I would not go back endonasal. I would think an open approach, classic Dolenk approach would be the next step. I do think with this case and the previous one, the anatomy of the carotid and determines very much your ability to get into the lateral compartment or not. There are cases where you have a good access to the lateral compartment. Some other cases with a tortuous carotid, it's just impossible. You can't do it. So you have to go to a lateral approach.
Yeah, that's what we did. I'm not going to go through videos here, but that's exactly what we did. We did this is the peeling of the middle fossa to reach laterally, and I'm not going to go through video for the time, but just to share the idea that exactly like what we did there.
But it's a great point, Danny. I mean, we need to be, as Paul also highlighted, we have to be good at both endonasal and open, and be wise on when to apply one or the other. And that's the beauty of our practice, is that we can apply one or the other depending on the case. Right.
Now, since we have another 5 minutes now, Paul, let me ask you this. I think what people really want to know is when, we know there's a limit on like you described very well, the limits of endoscopic endonasal for tuberculum sellae meningiomas. The question is case by case, right? What are the cases that you say, what, I'm going to go open? Or shall we go endonasal and leave a residue there? So could you elaborate a little more on your thoughts in what situations that you decided to just go ahead and do an open? And this is an example that you can use here. Do you see this second slide or no?
Yeah, I mean, this is a great example because we all show the slide of the standard one that comes out nicely, and even if it's big, we get a great result. But this, in my mind, is probably an unresectable tumor. Tumor. We lost your slide there, Danny. But there are two different aspects of it that make this a challenge. There's the vascular encasement, which is very clear encasement that I think, regardless of approach, it appears to be truly stuck inside there. And this is a case where I would plan to leave residual tumor behind, probably regardless of approach. The problem, I'm comfortable with being able to manage and dissect that vessel endonasally, but certainly that was not the case in the, early on an experience whatsoever. And it's foolish to think, that if you're comfortable more with managing those vessels from an open approach, that's the right approach. You know, that there is tumor going down into the sellae here, which is not resectable through an open approach. I mean, there are parts of this that no matter what you do, you're going to leave some residual through, depending on the specific approach that you choose, and it even invades into the sella. And so I think as long as you're honest with yourself and with the patient about what your residual is going to be, what the risk of olfaction is going to be, those are really the things that push me one way or another. When a tumor spills far forward onto the planum and posterior toward the posterior olfactory, and you have a patient in whom olfaction is really critical, like perhaps they're a wine expert, an enophile, or they're a chef or something, I will give them the choice. I'll help them understand the pros and cons and give them the choice. And so I think those functional things are a critical piece of it too. But I think early in someone's experience, even, you know, the first many of these cases, you have to do what's comfortable for you with that vasculature. And this is a tough case, one of the toughest ones I think you could approach. I would still do it endonasal. This is an incredibly hard case.
And would you sometimes recommend a combined, like a going staging, like a going endonasal for these in case there's a residual lateral, go open, or just watch?
Absolutely. I've learned the hard way that I don't do those in a rapid stage. I think that there's microvasculature that you are threatening on both sides of that nerve when you do an open versus an endonasal approach. And I think that your risk of, in my opinion, your risk of vision loss is a little higher if you approach both within either the same surgery or a short period of time. And there's no rush. You know, do the endonasal surgery, let them heal, understanding that you'll have to come back perhaps for that anterior clinoid residual.
And one more question, Paul, just to finalize, we're almost at the 40 minutes time here for our session. Do you think the McGill-McDermott, like a pointing system up to 6, which will be the more complex with invasion of the canal and surrounding the vessels, do you think that really predicts higher the number, less likely to do endonasal, or in your mind, you look at other details?
It does not answer the question for me about whether or not I would do it endonasally or not. I think it helps give us a jumping off point to compare cases. You know, if you're really comparing are the equal complexity and size being done, I think it gives us a grading scale for that. But I don't, you know, because the problem is optic canal invasion depends on where in the optic canal it's invading, whether or not that's, you know, so the anatomy is really what drives it. And unfortunately, the McGill-McDermott doesn't capture some of those nuances, but I do think it's a great comparator and a great way to understand the complexity of the cases. You know, like, for example, what you showed is clearly, you know, a grade 6 case. And so I think that helps us understand the complexity of it.
Yeah, so with this, I think we can finalize. I think the whole idea was not to have a too long of a webinar. I think the main message we got here today is that endoscopic endonasal is very versatile and excellent to approach the paracellular area, but there are limitations in the complementary approaches, like to the lateral aspect of the cavernous sinus. Sometimes we will need to do an open approach, as Dr. Miranda brought it up, and also for the lateral extensions of these anterior skull-based meningiomas as well. So with this, I really thank everybody's attention, and I'll pass the word to Dr. Hadpaginayas to finalize and give us the
I'll get you to say my name correctly one day, Danny.
Okay, one day.
Anyways,
Costas.
This was an awesome webinar, Juan, Paul, and Danny. I mean, I learned a lot watching you guys. These are what we want to do. These are provocative cases. These are not run-of-the-mill endonasal cases. These are the ones that are really, really need a lot of thought. And I thank you, the 3 of you, for putting this together. So awesome, and looking forward to the next one.
Thank you.
Thanks for putting this together.
Good to see you
Good
guys.
night, everybody.
See you guys next month. Take care.
Thank you.